Open the light here.
Hello, hello.
Hi.
We
There
can
you
just
go.
do a sound check as we're just waiting for Sarah.
Mhm.
Can you hear me okay?
Yeah, absolutely.
Okay, good. Good. Can everybody out there hear me? Welcome. Hello, hello.
Hmm.
Great. Good to see everybody. Everybody back here. Awesome. All right, we've got Sarah coming in. Her autopilot is here anyway. Okay, there we go. Great. Welcome, everyone.
Hello.
Hi.
Hello, hello, Sarah. Welcome.
Oh, what's going on here?
I almost made your autopilot the host. I don't know what would have happened.
I'm gonna remove it. Just give me 1 second. It's sort of, I set it up once and it keeps reappearing and I don't even use it.
I know I've seen that in a lot of meetings where it pops up and without the person asking it to.
Yes, exactly. It's kind of uninvited at this stage.
Let me stop the share.
Sure. Is the volume okay?
Yeah, can everybody hear Dr. Sarah okay?
Yep, that's good here.
Okay, perfect.
Yes, yes. Yvonne, haven't heard anything. Maybe just try turning up your volume or checking your settings. Yep, okay. Yeah, we're good.
Good, okay.
Okay, so I will go like that. And then we can get started. And then if you want to then share, if you have slides, if you want to share them.
Absolutely. Let me find them. It's always too many things open all at once.
That's great.
Yeah.
All right. Looks good.
Good. I'll just fixed up there. How's that?
Yep.
Perfect.
Yep, that works. I see it. Yeah, nice.
Okay.
All right. So why don't we just begin by welcome everyone. I think we're at about 6. And I know it's unusual to have a webinar on a Wednesday, but I so wanted to fit this in before everybody disperses for the summer. And I know a few of you have really been asking for this, and so I'm really happy to have Sarah back with us. But before we begin, I'll turn it to Mark to open us up from the clinic.
Yeah, right. Thanks, Sarah. This is great. Glad to have you back. The last series was really interesting, and thanks for coming on to do this one on IBS. It's really much appreciated. So yeah, a warm welcome from the Bill Melms Pain and Research Center. So thank you. Look forward to hearing what you have to say, and I can see we've got a number of our patients also interested. So I've just asked people to put any questions in the chat box. Madeline will monitor that and then run by later. So yeah, thanks and welcome back.
Thank you. Lovely to see everyone. I'm coming to you from my laptop today instead of my desktop, and it's small enough that I can't quite decide if I want my glasses on or off. I'm at that stage of of eyesight, so I'm not sure what I'll do.
I know that feeling. If you're far away for me, then I take my glasses off. If I'm up close, I've got them on.
No, and the arm length doesn't help me anymore either. So
yeah,
here we are. So, this is one of my my favorite topics. It's really my bread and butter, and probably what I spend the vast majority of my time on nowadays is irritable bowel syndrome, because it's so common And it's just such a big issue that I think it's just, there's so much demand in gastroenterology. So it's great to be able to have a chance to talk to everybody about this. And I suspect it's really quite common with the folks at the chronic pain clinic, because it's associated with so many other chronic pain conditions. It really often goes hand in hand with things like fibromyalgia, and other forms of chronic pain. And so I suspect that it's a big issue for lots of folks. So I thought what we'll do today is we'll talk a little bit about what is IBS, like what exactly does that mean, and how do we define it, and what do we need to worry about? So you know, I think knowing when to worry is an important thing, and we'll touch on that a little bit. And then we're really going to spend most of our time on nutrition strategies and some lifestyle intervention type strategies today to try and give you some tools in your toolkit to be able to manage IBS if it's something that you or a loved one is struggling with. So IBS is a disorder of the gut-brain axis. You know, we used to see patients and say, we've done all your tests, we've done every CT scan and colonoscopy and blood test under the sun. We can't find anything wrong, so it must be irritable bowel. And we don't do that anymore. IBS actually has a definition, and it's not sort of nothing. So IBS really relates to the disorder of how the gut and the brain are communicating with each other. And it's a disorder of function, not of structure. And this is really important because it means that when we do tests and investigations, blood work, imaging, scopes, they by definition will be normal because this is not a structural disease. And so nowadays, this is really a diagnosis that's made clinically based on symptoms and not on undertaking a whole bunch of different investigations, because they're usually normal and they're usually unnecessary. So there's something called the Rome criteria, which is kind of really boring, but it's an international consensus guideline on how to make a diagnosis of functional GI disorders. And IBS is one of a number of different disorders that sort of fall under disorders of function of the gut. And really to have IBS in general, this is a chronic condition. So people will have at least 1 day a week of symptoms for at least 3 months. And I'll tell you, most of my patients have had symptoms for 20 or 30 years. They often start at a young age, often in teenage years, late teens, early 20s, people start to develop some grumbling symptoms. And really it's changes related to having a bowel motion, to the consistency and the frequency of stools. And you need to have those symptoms there for at least 6 months. So, you know, for patients, I think the longer all of these symptoms go on, the more worried they become. And for gastroenterologists, it's actually more reassuring. The longer you have symptoms that sort of grumble along and are present and persistent, often the more they relate to diseases of function and are unlikely to relate to significant structural disease. Other things can be related to irritable bowel. So in addition to changes in bowel habits, people often will have what we call extraintestinal manifestations. So they might notice that they have like brain fog, for example. I hear that really often. Some musculoskeletal pain, maybe fibromyalgia. Some patients do notice that they've got some changes in urination. They may find that they have a frequent need to pass urine, or maybe some sort of like funny sensations related to that, but they don't have a bladder infection, for example. And then often upper GI symptoms go along with that. So that really, we call that functional dyspepsia, but a lot of patients bloating, gas, burping, they feel full quickly, they often get tummy aches. So all of these things sort of fall under that irritable bowel or functional gut symptom umbrella. And it's important to understand that within IBS, there's 4 different subtypes. So about 50% of people have a mixed subtype, meaning that they alternate between diarrhea and constipation. It's all over the map. and it can be very unpredictable and really hard to manage, but actually a majority of patients fall into that category. About 25% of patients have a constipation predominant subtype, and about 25% of people have a diarrhea predominant subtype. And this matters because it's important to understand that, that not everybody presents the same, not everybody has the same set of symptoms with irritable bowel, which means that the causes are probably a little bit different, and then the treatment strategies are a little bit different. So if you understand your subtype or your predominant bowel habit, it can kind of help you to figure out as we go what some of the more useful intervention strategies will be. And to be a little bit more targeted in your therapy. And it also may explain why you can have 2 people with irritable bowel and one thing will work for one person and the other will work for the other. It's because they're actually different subtypes. And I think a lot of what I see in terms of resources that are available from different sources tend to lump all IBS all together. And so it's kind of often a one-size-fits-all strategy, which is quite frequently ineffective or not super helpful. So IBS is really that disorder of function. It's not a disorder of structure. And I always say to people, it will make your life miserable, but it won't kill you. So it doesn't have negative outcome in terms of longevity or mortality or micronutrient deficiency or malabsorption. So it'll give you an awful lot of symptoms, but it tends not to be a malabsorptive disorder or something that's going to lead to more serious consequences. Having said that, there are some flags that you should know about if you've had a long-standing diagnosis of irritable bowel, or if something is changing. The things that make me concerned, especially when I see people who've had that long 20 to 30-year history of gut symptoms, are to really think about the following red flags. So one of them is a family history of either Crohn's disease or ulcerative colitis, inflammatory bowel disease, or a family history of colon cancer. We don't want to miss those diagnoses, and so we just want to make sure that people get appropriate screening. So there's very standard guidelines for colon cancer screening in throughout the world, and so if you've got a family history, we would want to follow those guidelines. As I mentioned, it's unusual to get new onset of symptoms after the age of 50. It for sure happens. But if they're new symptoms, it's again something we want to let your family physician or your referring physician know about, because often IBS symptoms start at quite a young age. As I mentioned, they start in those late teens, early 20s for a lot of people. And so symptom onset later in life, while it's possible, it's not the typical story. Weight loss that's unintended is an important thing to consider. I have a lot of patients that have weight loss because they're so symptomatic, they change their diet. That's not really unintentional weight loss because you know about it, you understand why it's happening. Unintentional weight loss is you're eating well, you're eating lots, and in spite of that, you're continuing to lose weight. That's a red flag. Blood in the stool, we always want to know about. Symptoms that wake you up at night are uncommon. So IBS tends not to cause you to wake up to go to the bathroom at night. And so that's something you'd want to know about. And then an iron deficiency anemia is always a flag in gastroenterology that you're either not absorbing iron properly, so there's a malabsorptive component, or that you're losing blood somewhere in the gut, and we'd want to investigate that. So those are really the big red flags. If you've got one of those, it's worth revisiting that diagnosis with a primary care provider, probably, just to make sure that something isn't new or changing or evolving. Often, things that are mislabeled as IBS can include celiac disease and Crohn's disease in a condition called microscopic colitis, all of which are very, very easy to screen for, mostly through standard blood work nowadays. So that it's quite easy to, check and make sure everything's okay just through a standard blood work panel. And now through stool studies, fecal calprotectin is a great way to screen for inflammation along the length of the GI tract. It's unlikely, if you meet those Rome criteria, that you've got an underlying cancer. And so the chances of missing a cancer or something more sinister like that with those criteria are actually very, very low. And you can be reassured about that. So IBS, really, it doesn't lead to cancer, and it does not turn into something more sinister like inflammatory bowel disease. It can overlap. So you can have Crohn's or colitis and have IBS, for example. So you can have both conditions, but one doesn't cause the other. And I think it's really important, again, to emphasize that having a colonoscopy or other tests for structural disorders are actually not going to make a diagnosis of irritable bowel syndrome. So it's kind of the equivalent of saying, I could take an X-ray of your leg, but it doesn't tell me how far you can run. It doesn't tell me the function of your leg. And IBS is kind of like that. So we can do a colonoscopy, we can do CT scans and look at the structure, but it doesn't tell us about function, which really is related to your symptoms. So that's what IBS is all about. And it's common. It affects probably 10 up to 20% of the population, depending on the study. And it's much more common in women than men. So probably about 3 to 1 is the ratio. We generally see it more often in women. IBS is expensive. It affects a large proportion of the population. About 40% of people seek medical attention. So it accounts for, in our healthcare system, actually a lot of medical visits. It is a substantial proportion of referrals to gastroenterology. So about 50% of referrals to general GI actually are related to functional gut disorders. And because it often affects young people, it tends to be a significant reason to be away from work or school. So the public health implications of that are actually really quite significant. So IBS is really this disorder of the gut-brain axis. That's what it comes down to. And the gut-brain axis is really what fuels the function of the gut. And it's a bidirectional conversation. So your brain talks to your gut talks to your brain, and they go back and forth. And in between that is the gut microbiome, which really functions as an intermediary or an interpreter between the brain and the gut. So this involves neural signals as well as hormonal signals between the brain and the gut that really go back and forth. And the hallmark of irritable bowel syndrome is visceral hypersensitivity. It's this sensitivity of the gut and intra-abdominal organs that's more than what you would expect for stimuli for somebody else. So for example, when we do colonoscopy, you can identify people with visceral hypersensitivity if you put air inside the gut or if you put a balloon inside the bowel. So someone with IBS, if we put a balloon in and inflate it, they'll get pain much sooner than someone who doesn't have IBS for the same amount of pressure from that balloon. So you can actually measure that when you do scopes or different types of testing. And so the key to IBS is really that visceral hypersensitivity. So the gut is more sensitive to inputs that go into it, whether they're inputs from food, for example, related to the gut microbiome, or whether they're inputs that come in from the brain or psychologically. The gut tends to be much more sensitive in those people with irritable bowel syndrome. So when we think about the gut-brain axis, it's actually really complicated because there's a lot of things that feed into that. We can think of things that feed into the gut-brain axis on the level of the brain. in terms of neurotransmitters. So we can think about the role of stress and life experience, how we cope with stress. And we can think about mental health disorders such as anxiety and depression, which really have a big impact on the gut-brain axis. We can think about the role of antibiotics and gut infections, as well as the gut microbiome, feeding directly into the bowel. And then, of course, diet and external substances, things like medication, or supplements or things that we consume, having a direct impact on the gut. So really, this conversation goes back and forth. And overlying that is our underlying genetic makeup, and then components of hypersensitivity of the bowel, how quickly the bowel is moving, the motility of the gut, permeability. A lot of us have heard of that concept of a leaky gut, for example, which may play a role in this. A huge proportion of our immune system is housed inside the bowel. Up to about 70% of the immune system is actually housed in the gut. So that may play a role. And the gut microbiome really is emerging as a significant contributor in all of this and how they all interact with each other. And so when we think about the causes of irritable bowel, they're multiple, not just one thing causes IBS. And so really we know that a number of different factors play a role in how IBS develops. And for some of us, some of these may be more or less important. So for example, some of us may have really significant food sensitivities and respond very well to dietary interventions. Some of us may actually have a lot of visceral hypersensitivity and pain sensitivity that responds better to pain management strategies. For some of us, there's a significant role for microbiome, and then for others, we may think really a lot about mental health, for example. So IBS is really that umbrella term where there's a number of different subtypes, and there's also a number of different contributors. And we know the gut microbiome is increasingly important in understanding irritable bowel syndrome. And it's not clear if this is cause or consequence. So we don't have a great understanding necessarily of what's chicken and egg when it comes to the gut microbiome and IBS, whether we get IBS and then develop an abnormal microbiome, or more likely we have an abnormal microbiome that drives towards visceral hypersensitivity, changes in motility, and maybe even neurotransmitters, for example, that then influences the development of irritable bowel. But we do know in IBS in general that patients tend to have a reduced diversity of the type of microbes in the colon, and that they also tend to have more of a pro-inflammatory set of bacteria. So really, when we think about this gut-brain axis, it's a complicated system, and there's multiple different inputs that come into it. But it also means that there's multiple different areas for intervention. And so when we think about this, each one of these things actually represents an opportunity to treat your irritable bowel. So most of the time, I think we end up being very, very focused in IBS on diet and external substances, at the risk of forgetting that all of these other factors also play into the development of irritable bowel and to the function of that gut-brain axis. So really, we can think very broadly about how to treat and manage IBS, because there's just so many different inputs into that system. And probably for most of us, there are multiple ways to feel better. So there's never just one strategy for IBS. There's usually multiple. And I think they work well when we do all of them together. So it takes a lot of work to intervene. And maybe I'll stop right there for a moment and just check in and see. I haven't been looking at the chat. So are there any questions or things that have come up here?
A couple things have popped up. First of all, like, I just want to say, like, right from the beginning, I think just knowing that it's what did you say? It's not structural, it's based on symptoms.
Yeah, it's functional and really based on symptoms. Yes.
can relieve so much stress about having it develop into cancer or something else. That there's something really wrong. I'm with I mean, obviously it's not easy, but there's nothing structurally wrong.
Yeah, and it won't, IBS doesn't progress, so it doesn't turn into something over time, which
Right.
isn't to say that it's mild. And I think that that's something that's always really surprising to people. You can have really severe symptoms that actually can be quite debilitating, and quite significant in terms of the impact on your quality of life. They won't impact your quantity of life, but they really can be quite severe, even though it's true, it's not a structural disorder.
Yeah, exactly. Like that's a little bit, that's a relief of stress right there.
Yeah.
Um, I just have one question in the chat, and I have one question. Oh shoot, I just lost it from Yvonne that came in earlier that was a little bit more specific. Paul asks, what is lazy bowel syndrome?
Well, lazy bowel syndrome is not really a medical term or a true syndrome. So, often from a medical standpoint, lazy bowel really refers to reduction in the motility or the contraction of the gut. And often we can see that in chronic constipation disorders. So that can relate to the inherent motility of the gut and how it usually contracts. So, we always think of having a heartbeat and how quickly our heart has a rhythm, but your gut also has a rhythm and a rate of contractility. And when that's slow, that rhythm is slow, it tends not to squeeze as quickly. And so that low motility can result in gut symptoms, often constipation, but sometimes other stomach and small bowel disorders. So it may be related inherently to the motility of the gut or to medications. Opiates, for example, would be a really common one that slowed gut motility. So so there's a number of different factors along that spectrum, and it's not one syndrome per se. We would look at underlying causes and factors within that.
Right. Thank you. Can the pain with IBS be as severe, Paige asks, as with IBD?
Yeah, the pain for IBS is actually the hallmark. Visceral hypersensitivity pain with IBS is like the biggest problem. And for many people, gas and bloating follows right behind that. And it's true that the definition relates to change in frequency or consistency of the stools. But most patients don't really care too much about, or less about, like constipation or diarrhea as they do about pain and gas and bloating. Those are really hallmarks, and they can be bad. But it's still very much a functional disorder in spite of the severity of the pain. And yeah, it can be as bad as IBD and other things. And in fact, often pain in irritable bowel is worse than pain in IBD.
Okay, interesting. Would age affect motility in the bowel?
It can, yeah. As we get older, we tend to have a reduction in motility of the gut. And so, it's one of the things that we often see constipation become more predominant in older adults, because there is a reduction in the inherent contractions of the gut over time.
Okay. I guess being less active too would make things slow down a little bit.
Less active, and then often more medications as we get older too, right? So a lot of things, like there's a number of different antihypertensives, for example, or pain medications, different things that actually slow the contraction of the gut. So yeah, that reduction in motility for a number of different reasons is much more common as we get older.
Right. Okay. Yeah, I think yeah, interesting. Those are the questions for now.
Awesome.
And I'm gonna, while you keep going, I'm gonna try that question, try to find that question of yours, Vaughn. But if you don't mind writing it again, that might help too.
Yeah. So, I know we've only got half an hour left, and so I'm gonna try and just touch on
Okay.
a few highlights, because I've got like hundreds of slides. I could go on.
Okay.
Forever. So I think the thing that I really want to emphasize is that there's a number of different interventions for irritable bowel, and they all matter on different levels. So diet tends to be the one that people really talk about the most, and it's important because about 70 to 80% at least of patients with irritable bowel identify diet as a trigger for their symptoms. They're pretty sure there's something in their diet that contributes to the development of their symptoms or the onset of symptoms. And the key is kind of just figuring out what that is. So diet is an important factor, although it's not the only driver. And within that, dietary fiber, and it's so many people have heard this so many times, and I've said it in some of our other series, and you know, it sounds like the most boring, ridiculous thing on the earth. Like, really, you're going to tell me about fiber again? Fiber is such a driver for gut health. And I won't spend a ton of time on it today, except to say that it is one of the primary interventions for irritable bowel because it helps with diarrhea, it helps with constipation, and it helps to have a healthy gut microbiome. So it really impacts symptoms in a number of ways, and it also impacts the gut microbiome. So when we consume fiber, a number of different things happen. There's soluble fiber and there's insoluble fiber. Fiber in general changes the viscosity of the fluid inside the gut. So it makes things thicker and gooier and slower. And that's really important because it actually helps to control blood glucose, and it helps to control lipid absorption from foods and fluids that are inside the gut with a meal. So fiber is important from a metabolic health perspective. It also can bind to things like phytates and iron. And it helps to reabsorb bile acids, which are an important cause of diarrhea for many, many people. So fiber can work in that way. Fiber is also fuel. It's a prebiotic. Fiber feeds the gut microbiome. It's incredibly important for having a healthy gut microbiome. And the gut microbes make something called short-chain fatty acids. And short-chain fatty acids, these are the three ones, are really important fuels for the health of the lining of the gut. So getting fiber gets us a healthy gut microbiome, which creates short-chain fatty acids, which helps to feed the lining of the gut cells. Fiber also gives bulk to the stool. So when we think about those muscular contractions of the gut, it gives it something to contract against. The colon needs, it's like the fiber is what provides us the structure to stool so that it can actually be pushed out by the muscles of the gut. And it changes the pH. These acids also change the pH. So that helps to inhibit the growth of less desirable bacteria or infectious organisms. So it really has a number of important elements or functions within the gut itself. In general, fiber has been very, very well studied for different interventions in irritable bowel. And it's important to note that different types of fiber have different impacts on the gut. And I think this is really where people get into trouble, because fiber can really be a double-edged sword for a lot of people with IBS. And the reason for that is that fiber ferments, which creates gas and air. And if you have gas and air inside the gut, you get stretch and distension, which triggers pain receptors, which triggers visceral hypersensitivity. So fiber, while it's incredibly important, also can produce symptoms because of the way it's broken down. And so the key to fiber is really understanding the difference between soluble and insoluble fiber, and being really careful with how you introduce it in order to get the benefits. So soluble fibers, which dissolve in water, generally are much better tolerated than insoluble fibers in IBS. So soluble fibers, we can think about things like oatmeal, for example, pectin in applesauce, those kinds of things that kind of are gel. Psyllium or Metamucil is a soluble fiber. They tend to really help regulate bowel motions and stool consistency. They slow down the emptying of the gut, and they're really important fuels for gut microbiome. And they've been shown over time to actually reduce visceral hypersensitivity, so that hallmark, that pain that's present for a lot of people, actually improves over time with the use of soluble fiber. Insoluble fiber is more like the roughage and adds a lot of bulk and structure to the stool, but it also, because it can expand, tends to cause people more symptoms. And so generally soluble type fibers are better tolerated. In IBS, we want to aim for around 20 to 25 grams of overall dietary fiber. You know, the average North American probably consumes about 10 to 15 grams of dietary fiber a day, and guidelines and recommendations for dietary fiber to reach about 30 to 35 for adults. So we know with IBS that they tend to need a little bit less than the overall population, just because of how well it's tolerated. But definitely the average North American diet is really low in dietary fiber and contributes to a lot of symptoms. So when I tell people to start fiber, I always tell them to start really, really low. If you decide to change your diet and all of a sudden start adding a whole bunch of fiber to it and do it suddenly, you will have so much gas and bloating, because the gut microbiome hasn't had time to adapt. Your gut hasn't had time to adapt to the fiber, and you'll get more pain related to that. You'll hate me. So the key is to start at a really low dose, and very slowly and gradually increase, probably like per week or every 2 weeks. So just tiny little doses, a really, really slow introduction with dietary fibers. And there's lots of different sources. So really, you know, I think look up the soluble fiber in particular and really focus on those ones rather than focusing on insoluble fiber. And a lot of people are FODMAP sensitive. We're going to talk about that a little bit today, but there are lots of low FODMAPs fibers that you can get, and those generally are quite well tolerated in irritable bowel syndrome. So that's kind of the fiber thing. It really is important, even though I know people hear it quite often. So that's one of the big ones. The other diet thing that we can really spend a lot of time on and takes a lot of time to delve into are FODMAPs. And I'm sure a lot of people here on our discussion today have tried a low FODMAPs diet. If you haven't, this is definitely something that you should check out if you've got irritable bowel. So FODMAPs is an acronym for fermentable, and that's the key. They're fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are foods that are they're constituents of very healthy food. There's nothing wrong with the food itself. And I often have people say to me, I'm a healthy eater. There's no way my diet can contribute to this. But they're healthy foods that have FODMAPs. And FODMAPs do two things. One is that because they're poorly absorbed and digested, they pull water into the bowel. They have an osmotic effect, which can cause diarrhea. And because they're not digested, they reach the colon intact, where they're fermented by the gut bacteria, which creates gas and air, which causes bloating and pain. So FODMAPs are very, very common, and they really tend to cause a lot of gas and abdominal distension. They increase gut motility. So as that fluid gets pulled in, it increases the motility, and it increases the sensitivity of the gut. So it increases that visceral hypersensitivity. One of the most important things to understand about the low FODMAPs diet is that it's 3 phases. The initial phase is a really strict restriction in low FODMAPs. So basically you take everything out, and the list is long. It's difficult and it's hard to do. And a lot of people would benefit from seeing a dietitian around that, because it's tricky. But often people feel better, and so they stay on it. And they can be on a low FODMAPs diet for months to years, which was actually never the goal of how a low FODMAPs diet was designed. That strict restriction is meant to be for a short period. It's meant to kind of give you a reset and a new baseline. So you take out all of these FODMAPs foods, which tend to cause a lot of symptoms. The second part of the diet is when you reintroduce those foods. And that's actually where the magic happens. This is the key, and it's the one that's really overlooked. People kind of get stuck in this restrictive phase, but it's actually the second phase where you slowly and gradually add foods back in that lets you identify if a food is a trigger food or a safe food. So when you add that food back in, if it's on the list, if it doesn't cause any symptoms and you don't feel any different after a few days or a week, then it's a safe food. You let it in, you allow it to come back into your diet, and you move on to the next thing. And then if that causes symptoms, you think, oh, okay, that's a trigger food. This is triggering my IBS symptoms. Let me play.
Sarah, I think you just froze. Unless it's me.
Identify safe from trigger foods, so that over the long term, the goal is to have a very personalized strategy with the smallest number of FODMAPs or restricted foods that you can, because really we want people to get abundance and diversity in their diet, because that's what fuels a healthy gut microbiome. It's more fun, it's more pleasurable. So long term, we're really trying to have the smallest number of foods restricted possible. So this is a super, super helpful diet for many, many people in identifying trigger foods and safe foods. And really, there's a lot of good resources out on the internet, but you know, the biggest thing I can say is that second phase of reintroduction is actually the key and really where the magic happens around identifying your triggers. So those are probably one of the more important components of diet and the best studied. So this diet, the low FODMAPs diet, has the best data to support it when we look at overall diet strategies for irritable bowel. Lactose intolerance affects about 70% of people with IBS. So lactose is a big one. And it is a FODMAP. It is a fermentable carbohydrate that causes gas and bloating when it's present, and it often very quickly, often within like 30 minutes of consuming dairy. And it tends to cause diarrhea because that poorly absorbed milk sugar really pulls a lot of fluid into the gut. So lactose intolerance is very, very common in IBS, and it's often a good place to start in terms of dietary modification. The other really common food constituent is monosaccharides, which include fructose. So fructose is sugar that's in a lot of fruits, for example, especially in the Okanagan. Apples, pears, pitted fruits tend to have a lot of fructose in them. And fructose intolerance or fructose malabsorption affects about 20% of people with irritable bowel. So if you're going to say to me, gosh, this FODMAPs diet has a long list of food and I don't know where to begin and there's a lot to it, the things that are common in FODMAPs are lactose, which is up to about 70% of people, and then fructose malabsorption, which is up to about 20% of people. So those are two easy places that you can often begin just to start to play around with diet. And fructose malabsorption is often it's often missed. People don't recognize it very often. So that's a really good place to start. Celiac disease is not a part of irritable bowel, and neither is wheat allergy. So celiac disease we want to identify early on when people come in with symptoms, and the blood test for celiac is 95% sensitive and specific. It is a good test for the vast majority of people to exclude celiac. Celiac is an autoimmune disease, and the consequences of it are really quite significant over the long term. So we do want to identify that. It's different from non-celiac wheat sensitivity or gluten sensitivity, which really is symptoms along a functional spectrum along the IBS spectrum. So in non-celiac wheat sensitivity, we don't have any antibodies. There's no intestinal damage, and there's no inflammatory or immune activation that occurs through this. So, you know, people often will find they're gluten sensitive or wheat sensitive, but they don't have any of the hallmarks of celiac disease. Often when people have a non-celiac wheat sensitivity, wheat contains a lot of oligosaccharides. And so for many people, if they tell me they're gluten sensitive, but they still have significant irritable bowel symptoms, I tell them to go back and cast the net wider and look for other FODMAPs, because wheat and related grains contain a lot of oligosaccharides, and often there's sort of a bigger category of foods that affect people. So if you think you're gluten sensitive, but you're still getting a lot of symptoms in your IBS, go back and revisit a low FODMAPs diet, because you often can find other triggers within that. How we eat is just as important as what we eat. So doing things that don't stimulate the gut as much can be helpful. So, you know, when we think about visceral hypersensitivity, those nerves and receptors in the gut are really stretch receptors. So when the gut is rapidly distended, or when it's very, very full, it doesn't matter if it's food or fluid or stool or air, it hurts, and it tends to cause us symptoms. So making sure that we have small meals, more regular meals, eating slowly, chewing properly, really slowing things down actually can have a big impact on overall gut symptoms. Reducing alcohol and fizzy drinks, same thing. They, you know, when we have carbonated beverages, it tends to really distend the gut. So we want to really work towards not having a lot of distension on the bowel. So avoiding carbonated beverages can be helpful. And then artificial sweeteners and sugar-free products, the non-nutritive sweeteners, are FODMAPs. They ferment, they cause gas and bloating, and they pull water into the bowel. So absorbing, if it ends in OL, it's probably a non-nutritive sweetener, and it's best avoided. So those are the big, you know, high level diet things. There's lots of little things, you know, that people can focus on, and sort of so many little details, but at a high level, those are the big diet suggestions. I think I would really be remiss if I didn't spend a little bit of time talking about the role of stress and the brain on the gut-brain axis. It's 50% of the equation when we think about the gut-brain axis and the role in irritable bowel. And you know, I've had so many conversations with other physicians. If stress is a big trigger for your IBS, you can't out-eat it. There's no diet in the world that's going to help you overcome a stressful situation if it's really something that flares and triggers your irritable bowel. And so I think it's important to spend a little bit of time on that, because it really does play a significant role in irritable bowel.
Sarah,
Yes,
I'm wondering if I could just wrap up with a couple of real super quick questions.
absolutely.
It's probably like a yes or no. Is stevia considered a FODMAP? Well, that's not a yes or no, I guess.
Yeah, it's not actually. It's not one of the ones that typically is a big trigger for people. Yeah, but I do think a lot of people have sensitivity to it. So, you know, those kind of foods, what I generally suggest is you take them out probably for about 4 weeks, not just a day or two. Get rid of, if you think, I wonder if this is causing my symptoms, get rid of it for about 4 weeks at least, see what happens. And then kind of reassess. And the reason I say at least 4 weeks, if not longer, is because when we think about this complex gut-brain axis and all of the things that are on here, you can't tell, you know, if stress is a trigger and you take out stevia or you take out lactose for a day or two, you can't tell if you feel better or worse because your mother-in-law is in town or because you took out the stevia. So when when you give it that big, long chunk of time, like, 4 to 8 weeks of taking something out, it kind of helps to level out the peaks and valleys and other factors that play into the gut-brain axis.
Right. That makes sense to isolate it. Yeah. SIBO, is it related? SIBO?
Yeah, so SIBO is very controversial. SIBO is small intestinal bacterial overgrowth. And it's one of those things that we're seeing a lot now in the media and different forms of literature. But when we look at the data that support the role of small intestinal bacterial overgrowth, it's probably relatively low. A lot of people will feel better when they have changes in their symptoms from antibiotics, for example, but it's because the antibiotics actually affect the colonic bacteria, the gut microbiome, more than actually affecting the small bowel bacterial overgrowth. So SIBO's, it's controversial, but it's probably not a big player for most people.
All right. Okay. And if someone was tested for previously for celiac, it was just under, should they go back and test again?
Probably
It
not.
sounds like it would. Okay.
Yeah, probably not. The scenario that's really, really challenging is if people have been on a strict gluten-free diet for a long time and they have celiac blood tests. The test will be negative because the antibodies go down with less exposure to gluten. So if you've been on a gluten-free diet for a long, long time, testing can be difficult in that circumstance. And often we ask you to consume some gluten so that we can retest.
That
Which,
makes sense.
if you're really symptomatic, it's hard to do. So that is a big challenge. And it's one of the reasons right at the outset of symptoms, we try and do blood work early on so that before you've gone on a gluten-free diet, you can have testing, which makes it so much more accurate.
Right. Okay. Okay, great. I just want to say that I'm not strict at the 1 hour cutoff, but I want to be respectful of your time. And we're recording, so if people have to leave, that if you still have more to say, don't panic if you have time.
I'm thinking
I want to say.
I want to rush through all this. I got 9 minutes.
It seems really important. So, but yeah.
I think the mental health is hugely important. I just can't underemphasize that. And we know that the gut-brain axis, like it really is driving this whole cycle. So when we look at patients with irritable bowel, about 40 to 60% of them will have another psychiatric diagnosis or disorder. That may be mild or it may be severe, but we often see it in conjunction with anxiety and depression, especially. And often, the worse the anxiety or depression, the worse the IBS. They tend to go hand in hand. And it's really interesting because one of the things that links both of those disorders is the gut microbiome. And so I think it'll be really interesting to see over time as we continue to learn and understand the gut microbiome, the degree to which that actually contributes to both IBS and mental health disorders, and whether we can change the gut microbiome to alleviate both of those things. So diet and mental health actually is really interesting to me, and I think we'll see more and more come out about that over the next few years. So regulation of the hypothalamic pituitary axis, our stress response, cortisol, is really important in irritable bowel because it affects so many different facets of gut function. And of course, when we have more anxiety, depression, stress, this changes a lot of different neurotransmitters and hormones, including cortisol. So stress, a little bit of stress is adaptive. Chronic high levels of stress can become pathological, and certainly IBS is no exception. And interestingly, stress affects the gut microbiome. And we can see that even at very young ages, in pediatric studies, as well as in rodent studies, for example, in the lab. So when young people or our young animals are exposed to more stress, their gut microbiome actually develops differently compared to those who aren't stressed. And that may play a long-term role in the development of irritable bowel type symptoms, and potentially mental health as well. So it's an interesting interaction. So we know that psychological stress increases our overall sensitivity, but the gut becomes more sensitive, so that underlying visceral hypersensitivity really is impacted by psychological stress. We know that stress hormones, neurotransmitters change gut motility, often by speeding it up. There's an impact on the immune system, which again, so much of our immune system is housed inside of the gut. It changes our behavior, and it changes the gut microbiome. So there's a number of different ways that stress is linked into that gut-brain axis. And because of that, there's actually been a lot of studies that have looked at whether or not we can intervene on irritable bowel from a psychological standpoint. And so the data is actually great for this. And so, like we focus so much on diet, I think that it's important to know there's actually really, really good data to focus in on mental health for treatment of IBS. And so there's some really good studies that have looked at cognitive behavioral therapy for around 8 to 12 weeks for treating IBS. And there's a number of different studies that have also looked at mindfulness and hypnotherapy that have shown good results for irritable bowel syndrome. So, particularly for those of you who found that you've tried a lot of different dietary interventions, my advice is to really go back and really revisit the mental health piece, because sometimes it's not a specific stressor. It's not, necessarily a particular life event. I think it's living in that fight or flight response, that sympathetic kind of drive that we often have in today's life, that kind of fuels stress hormones and cortisol, which actually have a big impact on gut function. So mindfulness and hypnotherapy techniques have both been studied in irritable bowel, have good results and good data. There's actually an app called Nerva. I have some patients that really, really like it. It's a self-guided hypnotherapy app specifically for irritable bowel syndrome. So it's very widely available. It is a paid app. I don't work for them, so no no endorsements there, but I do have a number of people that have found that quite helpful. So if you're not able to readily access psychotherapy or cognitive behavioral therapy, either due to cost or other access type things, that can be a really helpful app for from a hypnotherapy standpoint that's IBS specific. And then mindfulness techniques, and there's just so many out there. I mean, Madeline, I don't, you're the expert around all of that, but mindfulness has been very well studied in irritable bowel, and I really think that we probably all benefit from a little bit of mindfulness intervention around IBS. Stress management is shown to be helpful in terms of different types of relaxation techniques, but also exercise and sleep, which help us cope with stress better, have been shown to improve IBS symptoms. And I'll show you a little bit about that. But they're all really important constituents when we think about laying a really solid foundation for managing a complex disorder. Yoga has great evidence for IBS. So if you're able to do yoga, I strongly recommend it. And it's well supported again by the literature. So I think it's like the last thing that people would expect their gastroenterologist to tell them to do. But yoga is actually really helpful, probably for a number of different reasons. One is mindfulness and really achieving that mind-body connection. But also the postures related to IBS may be helpful in terms of stimulating the nervous system of the gut, the enteric nervous system. So yoga is well supported by the literature. And a lot of people probably would benefit from that. And the other thing that is very well supported by the literature is the use of antidepressants in irritable bowel syndrome. Again, they all kind of fall along the idea of modulating or changing the gut-brain axis. And I think, again, in the old days, we maybe somebody kind of got the message like, this is all in your head, just take an antidepressant and off you go, and don't bother me with all of this stuff. And I think that's a message that a lot of people kind of received over the years, and really deserves reframing, because antidepressants change the neurotransmitters in the gut, which can change how we sense pain. So particularly when visceral hypersensitivity and pain is a big issue, tricyclic antidepressants have very good data for their use in irritable bowel syndrome specifically. So amitriptyline or nortriptyline would be common medications that have been very well studied. So when we look at mental health for irritable bowel, really we can think about cognitive behavioral therapy, mindfulness, meditation techniques. We can think about yoga, and we can think about antidepressants, and all of them make sense for different people at different stages. But I think finding something in that realm that really complements other things you're doing from a diet and lifestyle standpoint are important and underemphasized. So one of the other things that we can think about is exercise. And exercise has an impact on a number of different elements of the gut. So there's obviously a lot of reasons to exercise. We know exercise is medicine. It's both prevention and treatment for a number of different chronic diseases. And gut health is certainly no exception. The more people exercise, the more diversity they tend to have of their gut microbiome. So when we think about needing abundance and diversity of food and nutrition, as fueling a healthy gut microbiome, we can also think about abundance and diversity in our physical activity, which fuels a healthy gut microbiome. It helps to promote gut motility. It has an anti-inflammatory response. Exercise affects the permeability, or like the leakiness of the gut, and it helps us to reduce stress, which feeds that back into that gut-brain axis. So there's a number of different ways that exercise is actually really important for overall gut health. And that also can help to contribute to those short-chain fatty acids that I mentioned, which are important for the lining and the health of the gut. So in general, exercise tends to increase gut motility or reduce transit time. So things will go through you more quickly when you exercise. Now, if you have a lot of diarrhea, that can be a challenge. And so timing of exercise becomes really key, where we try, most people tend to have bowel motions earlier in the day. So we try and get you to schedule your exercise classes or intervention for a little bit later in the day, so that you can actually get to class without having trouble. And some people will do things like use Imodium, for example, to slow the gut motility during exercise or before they go out for exercise. So I've got lots of patients that would use an Imodium before they go for a walk, for example, so that they can get the benefit of exercise without needing to find the bathroom in every park along the way. So exercise is especially important for those of you who suffer from constipation, whether it's irritable bowel related constipation or whether it's medication induced or something else. Exercise is one of the really key ways to stimulate the gut and get it moving. And it's got good data to support its use in irritable bowel syndrome, as well as in chronic abdominal pain. So an important mechanism there. And finally, I think I would be remiss if I didn't mention the gut microbiome, because it's such a key mediator in the gut-brain axis, and it really acts more like an interpreter in that conversation between the gut and the brain. So we know that, as I mentioned, patients with IBS tend to have less abundance and diversity in the gut microbiome compared to those who do not have IBS. However, there's not a specific fingerprint that's associated with irritable bowel. So it's not just one type of bacteria of the colon that contributes to an IBS-like picture. It seems like there's a number of different subtypes, a number of different fingerprints. So overall, the key message is that there's less abundance and less diversity in an irritable bowel compared to people who don't have IBS. And part of that, really feeds into how complex the interplay is between all of these elements, because the gut microbiome is influenced by diet and stress and medications and the immune system. And all of those things also contribute to irritable bowel. So they kind of all fit together, where they're really feeding into each other. So gut microbiome, we know is quite important. There's not a clear signature, which is why we don't generally advocate testing for gut microbiome. So I get that question a lot. Can I have a test for the gut microbiome, a stool test? Is that going to help me? And at this point, the answer is probably not, because there's not a clear microbiome that's been associated with IBS or a clear signature. And so in general, we want to promote a really healthy gut microbiome through abundance and diversity in food and nutrition. And that'll kind of benefit at the most people. So there's not a clear signature. And really, the key way to change your gut microbiome is through diet and nutrition. It's the number one lever that you can pull to change the gut microbiome. We often tend to think about things like probiotics, for example, but food, it matters more, especially over the long term. So the more you can get fruits and vegetables, whole grains and legumes, which really are very rich in fiber. Again, it goes back to fiber, as well as to other phytonutrients or chemicals in food, in particular in whole grains and fruits and vegetables that are rich in polyphenols or plant chemicals. They tend to be good for us as individuals, but they're also good for our gut bacteria. So that type of food is not just important for our skin and our hair and things like that. It's actually really important for the health of the gut microbiome. And again, fiber is really, really key in that. So getting lots of soluble fiber in particular is really important for maintaining a healthy microbiome over time. I always get questions about probiotics with IBS, and probiotics are live microorganisms. You have to get enough of them, so they need to be fairly concentrated to confer a health benefit. And they can be bacteria or non-bacterial. So for example, yeast or Saccharomyces boulardii is a very common probiotic that we use in gut health and GI disorders. And it's actually a yeast. And there's a lot of research around different species and strains. So what's available to us commercially may not necessarily be what was studied when we look at some of the data, which is probably why there's controversy in how well probiotics work in irritable bowel syndrome. So the research around probiotics and IBS is actually really quite mixed, to the point that different societies have come up with different recommendations. So for example, prior guidelines from the American College actually said there's probably not a lot of utility in using probiotics for IBS, whereas the Canadians and the British Society have actually said, well, it may be worth a shot. We could give them a try. So the data at this stage is a little bit all over the map. Some people feel like they get a lot of benefit from probiotics, others less so. So, you know, if you're going to try them, I think that the risk of harm is really low. Probiotics are safe. The biggest downside for most people is that they're expensive and they're not covered by health plans. So if you want to try a probiotic, it's a reasonable thing to do. Understand though that the literature and the evidence that support that is quite variable, and I think still really controversial and emerging. If you're going to try a probiotic, my recommendation is generally that you try it for about 8 to 12 weeks. Remember, when we take a probiotic, we want it to set up shop inside the gut. We want it to crowd out unhealthy bacteria. And then we want it to start to have the capacity to change at a microscopic level, inflammation and neurotransmitters, and then visceral hypersensitivity. So for all of that to happen and to be of benefit, you need to be on a probiotic for a while. So you probably won't find you get a lot of difference in your IBS symptoms after a week or two of probiotic therapy. You really need to give it an 8 to 12 week trial. And if you don't find it helpful at that stage, either abandon it or try a different probiotic, try a different strain, because it may be you just haven't hit on the one that you're missing. And it's hard to test and treat for that. So switch it up. So if you've been on a probiotic for a long time and you really are not convinced that it's helpful, don't stay on it. Go find a different one. Generally multi-strain probiotics are helpful. So usually they've got 3 or more different types of bacteria in them. And that's kind of where I'd recommend that you start. Remember that you can take all the probiotics in the world. If you don't feed them and have good, healthy nutrition, that you're not going to sustain that bacteria inside the gut. So good nutrition and probiotics really need to go hand in hand, because we want to naturally promote a healthy gut microbiome, but we also want to give the fuel that sustains those probiotics so that they set up shop inside your gut and can actually stay there over the long term. And the other thing to remember about probiotics is that while you're on them, they tend to be helpful. When you stop them, over time, they tend to wash out. They tend to go away. So if you've had benefit from a probiotic, you probably do need to stay on it over the long term in order to keep it inside the gut. So remember, there's lots of different interventions for IBS. I think that's the big takeaway that I want people to get from our talk today. There's a lot of different opportunity to intervene on IBS. We tend to think mostly around diet and nutrition, but don't forget that there's so many other levers that we can pull in terms of the gut-brain axis, gut microbiome, and then a huge role for stress and mental health in this whole picture that represents a really good opportunity to make things better. So I'm happy to take any other questions. I can see lots of things in the chat there.
It has been busy. It's been great. So many, good comments and questions. We could probably get a few of the other. Do you have any recommendation for a probiotic? Someone says, I've been told there's only one effective probiotic available in Canada. Do you know of any brands?
Oh gosh, you know what? There are so many different brands on the market, and different people respond differently to different probiotics. So this actually, if people want to scan this, I've shown it before in one of my slide decks. And so if you want to scan that, it should lead you to a really, really good resource on using probiotics in gut health that's Canadian. So you can just scan that QRS code. It depends a little bit on whether you're diarrhea predominant or constipation predominant in terms of your symptoms and which probiotic to use. And so in general, most people do better with a multi-strain formula. And Yeah, if you look at the Canadian Digestive Health Foundation website, cdhf.ca, they've got a number of really good links to probiotic resources, because different probiotics, you know, we can use them for irritable bowel, we can use them for antibiotic-associated diarrhea, we can use them for inflammatory bowel disease. So all of those different disorders actually have different data sets around them. And yeah, I think, you know, you do have to be a little bit buyer beware. So check out the CDHF website. That's a good resource. CDHF, the Canadian Digestive Health Foundation. It's got a lot of great stuff on it.
Okay, great. And then I just put the document from the scanned document in the chat if anybody wants to have a look at it. Does self-massage of the abdomen help?
Yeah, certainly people have looked at massage for IBS, and I've got the data, the scientific data that support its use are not very strong. And part of the reason is you can't placebo control that. I mean, you know, if you're going to get an abdominal massage. So it's not been very well studied. Having said that, I have a lot of patients that find it helpful, especially for gas that causes a lot of pain, and especially for constipation. And most massage therapists are trained in abdominal massage if you ask for it specifically. So if you've got a practitioner that you really trust. And the other thing is, like, a lot of people notice they pass gas and air when they're having abdominal massage. So be forewarned about that, because
Right.
you want to have that conversation with your massage therapist, and you know, it is what it is. But
Yeah.
but do
So you
expect
don't
that.
have to worry and, you know, be afraid that you're gonna
No,
pass gas while you're having it.
and they know that you'll probably will pass gas if you're getting an abdominal massage. So it is kind of part of the part of the deal. Yeah, but people can
Right.
find it very, very helpful. Similarly, you know, the data around acupuncture are not very strong when we look at the literature for it, but when we're talking about visceral hypersensitivity and pain, there are a number of people that find acupuncture quite helpful for managing that type of pain. So for some people, that's also a consideration.
Okay. Yeah, I love that there's so many options, like there's so many doorways and so many choices to try to expand your, you know, your, that, like you say, to pull there's many levers to pull.
There are, and I think that often it's the small little things all together that really add up for good results and for big results. You know, in my experience, often we get very focused on just one and diet in particular, when really, if we combined that with stress management and sleep and exercise, the impact would be so much greater.
Right. Right. Okay. Let's finish off with some questions from Yvonne. Now, Yvonne, I think we talked about the probiotics, so hopefully we're good on that. One of my feeds, I received a couple of articles on gut mucosa. Could you explain a little about that and how I should deal with it?
So gut mucosa is really just referring to the lining of the bowel. And in IBS specifically, the mucosa of the gut is not particularly affected. So that's why I would say it's not a structural disorder. So if you have a colonoscopy or you have a gastroscopy, you have biopsies, it looks normal under the microscope. So it's really a disorder of structure or function, and not of structure. So the mucosa should not be affected in IBS. If we look at a very microscopic level, things start to get a little bit more controversial about whether or not there's sort of very low-grade inflammation changes, very low-grade leaky gut sort of concept. And that's actually been very, very controversial in the literature. And most gastroenterologists don't feel that inflammation is a really big player in the development of IBS symptoms. It probably relates more to that visceral hypersensitivity and the role of the nervous system more than it does to the mucosa or the lining of the gut.
That's so interesting. Wow. Okay. I'll say one last question. Do you or maybe anybody else here know of any apps that you might suggest to help with the FODMAP diet? Are there any apps you can
Oh
use?
gosh, there are so many. Then the app that I generally recommend is the one that you like. Like, we all do this. We buy an app that we hear about and we think is fantastic, but it doesn't, I don't know, it's not intuitive to us, or we don't like the colors, or there's just something about it that's not user friendly.
Yeah, that's so true.
And then we don't use it. So the first thing is like play around with a couple of sample a few to find one that you think this is I can use. I can really kind of dig into it, because that's the one that's going to give you the most utility. In terms of FODMAP specifically, the Monash University, Monash, Monash, which is based out of Australia, they have an excellent website. So if you search low FODMAPs, Monash University, and they have an app. It can be quite detailed, and there's a lot in there, and some people find it's a little bit like almost too much or a little bit cumbersome, but the quality of the information in that is really, really good. And Monash University were the originators of the low FODMAP diet and the original studies around FODMAP. So that's my go-to for in general.
Those Australians, they're always a few steps ahead.
Yeah. So that's my favorite. But there are many out there, and lots of very, very good ones.
Okay, excellent. Well, I think we covered pretty much everything. What a jam-packed webinar, and thank you for staying over time.
Oh, my pleasure.
And this is all recorded, and it will be posted on our website, so you can go back and go over it again, and looking at all those different choices and levers I like that image. I'm going to pull this lever to try and keep trying. I have put Dr. Sarah's website back in the chat here, sarahrobinsmd.com, and also wealthsunday.com. They're both, I've looked at them both. They're just so worth checking out for all of this type of information, and to see what Dr. Sarah offers. So once again, I want to thank you for being here for us, and continuing to do the work that you do to help people in lifestyle and nutrition to gain control over their health.
Yeah, thank you. Thank you for having me. It's great to get to reach out and be involved. So I'm really super grateful. And I know if there's some extra questions, you can filter them through the pain clinic, and I'll hear about them, and we'll either send answers out in the newsletter or back out through the pain clinic. So yeah, I always appreciate feedback. Thank you so much.
Great. Thank you. And thanks to everyone for being here. We have one more class with, we've got Juliet tomorrow at 10 for the regular yoga for pain. And then next week, one last class with Juliet on the Tuesday. And then we say goodbye for the summer. So thanks for being here tonight. Have a good night, everyone.
Good night.